Good morning. Gives me great pleasure to welcome you to the first annual Peter B. Dent Memorial Lecture. Special welcome to Peter's family, his lovely wife, Diane, and his beautiful daughters, Jennifer, Ashley, and her husband, Andre, as well as Rebecca, who have traveled long distances to be here with us today and make this a special event. Today's event has been made possible by you, our faculty, our staff, our friends, family, patients, and colleagues of the late Peter Dent. With your support and through the work of our hospital and university foundations, we've raised $500,000 for the Peter B. Dent Memorial Legacy Funds, which are being invested in programming like this to advance excellence in pediatric care, research, and training. Today's lecture is the first in a series of programs that include the Peter B. Dent Memorial Resident Scholarship in Pediatrics, as well as the Peter B. Dent Memorial Research Impact Fund. Personally, it's been an honor to work with the Dent family and partners across our institutions over the past several months to bring this program to fruition. It is particularly meaningful to gather today, as tomorrow marks 1 year since we lost this great gentleman, Dr. Dent. For those who might not know, Peter's interests in pediatric medicine and research started when he was a child himself, when he suffered from earaches and was hospitalized, and came to recognize the importance of child health care from a very young and personal lens. Just realized I don't need to wear this anymore. Sorry, used to wearing it all the time around the hospital. Let's take that off for a second. That formative experience later led him to a medical degree in pediatric training in Toronto, pathology training in Birmingham, England, and later a fellowship in immunology in Minnesota under Dr. Robert Good, one of the founders of immunology. When he returned to Canada in 1968, Peter came here to McMaster University as a clinical scientist with a research focus in cancer immunology and pediatric rheumatology. I'll let our guest speaker, Dr. Maggie Larché, share more about Peter's research impact in just a few moments. Although research was a passion and focus of Peter's career, he was known across our community in many capacities: as a pediatrician, a professor, an innovator, a mentor, a community leader, a care provider, and a husband and father. Among the countless achievements made during his 50-year career, which includes a decade holding the position of chief and chair of the Department of Pediatrics, he will always be remembered as the driving force behind the creation of what is now known as McMaster Children's Hospital and the adjacent Ronald McDonald House. Peter pursued a bold vision to develop a standalone pediatric healthcare center of excellence in our community, a place where children and families facing the most critical and challenging health conditions could easily access world-class specialty medicine, treatment, and care. Serving the needs of this unique patient population was as important then as it is today. And more than 30 years later, hundreds of thousands of children and families from Hamilton and across Southern Ontario have benefited from Dr. Dent's passion and efforts. McMaster Children's Hospital continues to stand tall amongst its peers and is a beacon in our community thanks to the strong foundation laid by Dr. Dent, upon which we continue to build. Now, for those of you who are able to join us in person today, we've gathered here at McMaster University during a time, Thursday mornings at 8 o'clock, which is usually reserved for our pediatric grand rounds. Each week, Peter sat in the front few rows of grand rounds, and since my arrival at the end of 2018, Peter would find a way to come over to the couple of seats where I was sitting And as we were milling about and getting ready to get started, he would find a few moments to nudge me with his elbow and say, "How are you doing? How are things going?" And it was his way of checking in with me and making himself available. Some days I would say, "Great, everything's roses." Other days I would sigh and say, "Peter, I need some advice. Hey, what do we do with this?" But he was always there in a very unassuming and humble way, but he'd always just appear. So today, we've reserved Peter's seat, and we have laid his signature white lab coat on his chair. In the pocket of that lab coat is his notebook, which for those of you who had the pleasure of working with him, you'll remember he always had at the ready. And so this is pre-cell phones, electronic media. This is flip notebook with every important phone number, contact information, little tidbits. And when I saw that we had that and the team brought it forward to me and we got to flip through it, you instantly feel like you're touching and communicating with Peter. So today his seat is also marked with his beloved dahlias. It's fitting that Peter had an affinity for these flowers, which he cultivated in his garden, as dahlias symbolize commitment, kindness, and steadfastness, due to their ability to bloom after many other flowers have died. I think you'll all agree that these flowers aptly represent the way he built his career and the way his legacy will continue to contribute long after his passing. With that, I'm so pleased to welcome the Peter B. Dent Memorial Lecture's first ever speaker, Dr. Maggie Larché. Dr. Larché is a professor in the Department of Medicine and associate member of the Department of Pediatrics at McMaster. Like Dr. Dent before her, she is a rheumatologist. She has an interest in developing curative treatments for patients with systemic sclerosis and inflammatory arthritis. She works with immunologists and other clinicians from McMaster and across Canada, North America, and globally to build relationships with researchers, granting agencies, and industry partners to facilitate innovations and collaborations in biomarkers in rheumatoid arthritis, interstitial lung disease, SARS-CoV-2, and in systemic sclerosis. We're thrilled to welcome Dr. Larché to the platform to share her topic, Lessons Learned from Dr. Dent. Following Dr. Larché's presentation, for those who are here in person, we invite you to join us downstairs in the MDCL atrium between 9 and 10 for our informal gathering that will allow us a chance to socialize and share memories and stories of our beloved Dr. Dent. Dr. Larché.
Thanks so much, Angelo, for that kind introduction. I'm really excited to be here today to talk to you about my friend and colleague, Dr. Peter Dent. And I would like to title my presentation, The Spirit of Collaboration, because Peter shone his shining light on all of us and was a master at collaboration. So I'll talk to you about that in these next 40 minutes or so. I'd like to thank the organizing committee and the whole Dent family for inviting me to present the inaugural Peter Dent Memorial Lecture. So the outline for today really is to describe some of the valuable lessons that Peter Dent taught us all. I want to outline some of the important clinical and research initiatives inspired by him, and to highlight some of my own ongoing research efforts. So how would we describe Peter? P for perseverance. He had incredible perseverance. He was able to, for example, get the McMaster Children's Hospital off the ground, and it now is its own entity, as you've seen. He had enthusiasm. Every day I would see him and he'd be excited about the day ahead, the patients that we were going to see, what we were going to learn today. And he went on like that throughout his career that I knew him. When Peter said he was going to do something, he did it, and he did it really well. He was incredibly trustworthy in the 17 years that I've known him, incredibly trustworthy and able to carry something through to the very end. We all know that warm hand on the back of our backs from Peter, the warm embrace, the loving look that really warmly encouraged all of us in the field of academic rheumatology in my instance. And he was the rock. He was a rock to me throughout my academic career, and I'm sure he was a rock to many of us here in the room and beyond. I don't know if any of you saw this cloud this morning. It was absolutely incredibly well lit up from the sun round the back of the cloud as the sun was rising. And I thought of Peter when I saw that cloud, and I thought of him even more when the sun poked its rays out from amongst that cloud there and shone directly in my eyes. And that was Peter's cheekiness, giving me a little bit of a hard time getting to this lecture this morning. I've entitled my talk, The Spirit of Collaboration, and that's one word that really shines through when you think about Peter. He was a master collaborator, able to juggle both academic missions, but also his administrative roles, at which he was incredible. Other words that you can use, adjectives to describe Peter: charm, wit, empathy. My experience with him and patience, he called everybody sweetie pie, by the way, which was really cute. But my experience with his empathy was enormous, not only to the patient themselves, but also to the parents and the caregivers who were with Peter and with the patient at the time. And these are all amazing attributes for a wonderful clinician, and that's why he's been such a great mentor to me. In terms of what lessons I, and I hope others, have learnt from Peter over the years, these are the ones that have come to my mind, and then I polled several of you across the audience and perhaps internationally. The first one really is to make sure you ask for help. If you don't know, ask. One of the diseases I see a lot of is a disease called systemic sclerosis, which is a multi-system complex disease requiring multiple specialists. I view myself as a quarterback, throwing that ball to the next specialist. How can I get the best for this patient at this time? And I've learnt that lesson from Peter, to ask for help when I need it. He also was the master at listening quietly to multiple opinions before he made a decision himself with regard to how to move forward. So his quiet role as an advocate and as a master administrator comes from listening to multiple opinions. He has always suggested keeping a good sense of humour, and we would frequently have a smile and a laugh whilst we're in clinic when we could think of the humour in the situation. Ross Petty, Dr. Ross Petty, who's a professor of pediatrics, told me that they holidayed together quite frequently, and Peter's mantra was, never take the same route twice. And the question is, why would you say that? Well, it's boring. And Peter didn't like to be boring. He liked to be pushing the boundaries, never take that same route twice. And in a career, that's good guidance as well. And he also was very masterful at embracing technology. I will talk in much more detail in a few minutes, but he was integral at setting up the Pediatric Rheumatology Bulletin Board, which is an electronic means of communication amongst us all. What about accolades for Peter? You've heard a little bit about that from Angelo in the introduction. He set up the Ronald McDonald House, which those of you who don't know what that is, it's an incredible resource for relatives of patients who are in the pediatric hospital. These relatives may live a long way away and can't commute back and forward. So the Ronald McDonald House is a place of safe haven for parents and family members of patients in the hospital. And Peter had dogged determination to get this up and running, and it's a wonderful resource for our patients. As I said earlier, and you've heard earlier, he founded the McMaster Children's Hospital. And again, without his perseverance, that wouldn't have happened. He became a master of the American College of Rheumatology. That's a great accolade for anyone. And Peter, on the basis of his academic merit, was awarded this master status. He was the administrator and one of the orchestrators of the alternate funding plan for the pediatricians at McMaster. And that's been a game changer for academic pediatrics, academic medicine, for those people involved. And most recently, he's been awarded, quite rightly, the Order of Canada. And there's a lovely picture of him with his medal and with his beautiful family below. Those in the audience here, lovely to see you all. What about Peter's journey through research? Well, actually similar to me. It started with cellular immunology and moved through genetics, environment, clinical phenotyping, epidemiological studies, case reports, and finally, all of those were designed to find clinical solutions to a clinical problem. And I'll highlight some of his work now. He moved to Minnesota as a junior doctor to work specifically with Dr. Robert Good, who is well recognized to be the father of modern immunology. And Dr. Robert Good was such a draw for Peter and Diane that they went and lived in Minnesota, I believe, for 2 years. And Robert Good was famous for many things, including the first successful bone marrow transplant. Can you imagine how that's transformed medicine into much better clinical care for our patients? He worked alongside Dr. Max Cooper, who has maintained his scientific career very vigorously, and indeed won a very illustrious prize called the Lasker Award in 2019. Some people feel that that is somewhat of a prequel to the Nobel Prize. So watch this space. I hope you certainly deserve that, Dr. Max Cooper, from what I've read. So these are some of the basic science abstracts and papers that Peter has published in his early days. They were basic science, and you could say, why is a pediatrician, why is somebody interested in avian or chicken immunology? Well, I'll show you. He was initially looking at how cells respond and react in terms of he initially was looking at how avian cells respond to how immunological triggers will generate lymphopoiesis. And these are a couple of his basic science papers. And more recently, or at least towards the end of his time at Minnesota, he was looking at malignancy and leukemia, the development of leukemia and skin graft rejection in tumor development. So really basic immunology. I love this quote from Robert Good, which I dug up. It's slightly disheartening, but it comes with a really great nugget at the end. So those of us who publish papers, a few people see it, a fewer people read it, hardly anybody remembers it, and then you forget it yourself after a year or two. So that's quite funny. But if you teach something, you propagate something, and it multiplies. And Peter Dent has taught me that. Peter Dent is the father of rheumatology immunology at McMaster. There's the three scoundrels in the left-hand photo there. The late Dr. John Bienenstock and Dan Perry, along with Peter Dent at the very back. And of the three, you can probably agree with me that Peter looks probably the least mischievous. Anyway, they were the founding fathers of immunology, and Peter brought in rheumatology with immunology there. He also worked closely with Jerry Dolovich, the late Jerry Dolovich, who was also a key member of the immunology, allergy side of immunology at McMaster. And along with Stephanie Atkinson, I think these three are probably scoundrels too, but along with Stephanie Atkinson, the three of them developed a really robust pediatric immunology program. And I'd like to thank Myrna Dolovich and Carl Richards and Jack Goldie for these photos. What about more recently? Peter's been involved in case reports, case series, and cohort studies, and those have allowed him to continue his research portfolio despite predominantly being an administrator. And here's a lovely photo of the late John Bienenstock again with Peter at a Department of Medicine dinner not too long ago. Moving on to his embrace of technology, I canvassed opinions again across the world, and Dr. Lisa Ryder, who is the head of environmental autoimmunity group at the NIH, gave me this statement and said that he was absolutely visionary in his establishment of the bulletin board. And I'll tell you what the bulletin board was about. It's a worldwide network of pediatric rheumatologists and other people who are interested. It fosters collaboration in teaching and research, especially in the rare diseases. And I'm going to give you an example of myositis and scleroderma and how Peter Dent's Pediatric Rheumatology Bulletin Board has transformed that. It's allowed new studies with sufficient rationale and adequate power. And we also are able to discuss really challenging cases. And that's a lot of fun because we bring a challenging case to the table, and amongst us we can discuss how to handle that case. And it's also a way of disseminating news, and I'll give you an example of that as well. And really it benefits from the collective wisdom. And I couldn't resist this quote from the Queen, who said that none of us has a monopoly on wisdom. And again, that goes back to the discussion about teamwork and collaboration. It's all about that, and none of us knows everything, so we should be humble. So all of these with the Pediatric Rheumatology Bulletin Board improve patient care, and that's what Peter was all about. In terms of disseminating news, the Order of Canada was discussed by Dr. Ron Laxer from the University of Toronto, who many of us have trained with and had close collaborations with over the years. And Ron Laxer made the announcement that Peter had been awarded the Order of Canada across the world using Peter Dent's bulletin board. What about fostering collaboration in research? A disease that's dear to my heart, scleroderma or systemic sclerosis, is really uncommon in children. It occurs in about 1 in a million. Think of that. 1 in a million children get this disease. So how can you possibly do any research in this condition? You can't without collaboration. And what the Pediatric Rheumatology Bulletin Board listserv was able to do was pull in 49 centres across the world. Here's a world map taken from their website. And they now have over 200 patients in this cohort. And they've had 45 abstracts and 3 published papers so far. It's just pushing the boundary of knowledge and improving patient care. Similarly, the juvenile myositis cohort led by Dr. Lisa Ryder, who I mentioned earlier, has already enrolled over 300 patients with inflammatory myositis. And again, pushing the boundaries of how do we find better biomarkers? How do we identify and phenotype these patients better such that we can provide them with the appropriate medications? So these have really fostered collaborations. In terms of how my career has developed because of Peter, I'm going to talk through some of these boxes here. In terms of clinical teamwork, I was telling you I feel like the quarterback. I have affiliated closely with respirologists, gastroenterologists listed here, and many other specialists in fields that I'm not terribly familiar with. So collaborating in clinical teamwork important. Adolescent care with the pediatric rheumatology transition clinics. I was one of the instigators of that along with Peter, and then I will talk about the people who have really expanded this field in pediatric rheumatology at McMaster. I have been lucky to be involved in some epidemiological collaborations. For example, the Global Rheumatology Alliance, which was started to look at patients during the COVID pandemic and see if we can help them with their journey with the virus along with their disease. I've been involved in advocacy to try and improve care, and I'll talk about that in a lot more detail. Peter taught me that when one door closes, another door opens, and that's been a really true statement for me. I recently became director of the Canadian Scleroderma Research Group, which is an amazing opportunity. And I've had several opportunities for immunology collaborations where I've been allowed to follow my heart, which is in basic science like Peter's was. So what about adolescent care, the pediatric rheumatology transition clinics now? I'll tell you about pediatric rheumatology at McMaster. Peter was single-handed for many, many years. I actually don't know how many years. Until 2006, when he invited me to join him one day a week. So I did 1 day a week of pediatric rheumatology alongside him, which I thoroughly enjoyed. While I was still in place, we recruited Dr. Tanya Cellucci, here in the top left picture. And a year or so later, we recruited Dr. Michel Batiche. And rather cheekily, the three of us called ourselves the Charlie's Angels, with Peter in the background as the chief operating officer of the aforesaid Charlie's Angels. And we got up to lots of work and a little bit of mischief, which was fun. Then came Dr. Ray Braga, who is a pediatric immunologist and was working alongside Peter for several years, and Dr. Leanne Heel. So from a single-handed practice, Dr. Peter Dent has expanded into 3.5 people now in pediatric rheumatology. They have exploded the field of transition medicine for our pediatric patients and caring for our young adults. They have been integral in getting research grants and promoting more research in this field. So for example, the top box here is the transition readiness. How ready are our pediatric patients to start and be looked after by us mean adult rheumatologists? How ready are they? And transition readiness is really important because there's no need for that horrible anxiety of changing physicians if we can make that journey smooth. And that's what Michelle and Tanya and some of our adult colleagues listed in the bottom there have been able to achieve. They measured readiness for transition to adult care, and that, as you could imagine, that readiness increases with age, and goal setting really helps with increasing readiness. So those are all tools that we learnt. And in the bottom part here, they also extrapolated that to, okay, how can we help parents get their children ready for transition? And they've developed a toolkit, an educational toolkit for parents and their children to be ready for transition into adult rheumatology care. Moving on to some of the collaborations I've been really vigorously involved with, I mentioned earlier, this stemmed from the clinical question of my patients, Doctor, I have an autoimmune disease and I'm on these medications that damp down my immune system. Am I at risk of worse COVID? Am I at risk of more likelihood of getting COVID, and is it going to be significantly worse? So I was fortunate to join the Global Rheumatology Alliance looking at exactly this question. So one of the studies we looked at, I won't go into all of them in detail, but one of the studies we looked at was really interesting because a very famous person decided to make it public that hydroxychloroquine was not only a good treatment, but was also preventative for COVID-19 infection. And he made this very public, and you know what happened? Well, what happened was that hydroxychloroquine, a drug that we use every day in our patients with lupus and with rheumatoid and inflammatory arthritis, flew off the shelves. There was none left for our patients. So this was a big problem. So with the Global Rheumatology Alliance, what we really wanted to do was determine whether, number one, our patients who were actually still taking hydroxychloroquine were getting more or less COVID infections, more or fewer COVID infections. So that's number one. Is it efficacious? Maybe it is, and maybe Donald Trump, you're correct. But our hypothesis was that there really was no grounding for that theory. So we wanted to look at that, and we also wanted to look at what the effect of having this drug flying off the shelves for people who think that it's going to protect them from COVID was on our patients. So we looked at that. We had over 9,000 patients who responded to our questionnaire, and more than 3,000 of those were on this drug, hydroxychloroquine, or an antimalarial. And we showed that there were similar rates of COVID infection amongst patients taking that medication compared to patients not taking that medication. But we also showed that across the world, there was a shortage of availability of that medication in 6.2% of patients who responded. Really crucially, what you see is a massive disparity across the world. You see in Southeast Asia and in Africa, there was massive shortages, 20 to 30% shortage of this medication for our patients who need this medication. But in European regions, only 2%. And we also showed that there was a higher rate of symptom flare in those patients who experienced a shortage. So interesting clinical question there. Another study from the Global Rheumatology Alliance, again, was very pertinent to clinical practice, and we showed that patients with autoimmune diseases on immunosuppressive medications did indeed have a slightly prolonged COVID symptom duration. And I'll show you this. This is the data in very brief terms. We had more than 400 patients across the cohort who had a rheumatological disease and got SARS-CoV-2 infection or COVID infection. Their median symptom duration was 15 days, and the general population was between 7 and 12 days, so slightly higher symptom duration. But 1 in 4 had a symptom duration of more than 28 days, and 1 in 10 had symptoms of more than 90 days. 90 days of a COVID-like or a COVID symptomatology. And we found that the longer symptom duration was associated with older age, acute severity of COVID. How bad was it when you first got it? The worse it was on first presentation, the longer it lasted. And other comorbidities were predictive of a longer duration. And interestingly, as the pandemic went on, later on in the pandemic, fewer patients had prolonged symptoms. And we hypothesized that that could be multifactorial. Repeated vaccinations, the availability of Paxlovid, the treatment for COVID, and maybe just recall bias that the patient couldn't remember. What about my work in advocacy? This has been so exciting. You may have heard of drugs called tadalafil and sildenafil. These are drugs that are used for erectile dysfunction. You say, well, what's a rheumatologist got to do with that? Well, Viagra and Cialis, or the other way around, Cialis and Viagra are drugs that open up the blood supply, and they open up the blood supply to patients with systemic sclerosis who have ulcers on their fingertips. And all of us, I think, can remember that we've had a paper cut. And when you have a paper cut on your index finger, it's actually really sore and really hard to function, but you know it's only going to last for a day. By tomorrow, it'll be much better, and you'll be able to type, you'll be able to get a key in the door. These patients with systemic sclerosis get ulcers on their fingertips, which can sometimes, like this photograph, become gangrenous. These patients have ulcers on their fingertips that last for months, 6 months, 12 months. You get no respite in the pain. It's a total disaster. I have one patient who's a dental hygienist, and she can't work. Her fingers are so sore and kind of clumsy that she can't work anymore. She's lost her job because of a finger ulcer. So this is really important. And we know there's good evidence that those drugs, tadalafil and sildenafil, can help reverse digital ulcers, help heal them more quickly, and prevent the development of new ulcers. So we, for 3 years running, have been to Queen's Park, and we've met with Dr. Christine Elliott, who has been the health minister. And when I say we, it's with Scleroderma Canada and Scleroderma Ontario, and we've been pushing for development in this availability of these drugs for our patients. So this was the first meeting. We saw Christine Elliott in person, and this is what the pandemic did to us. We saw her by Zoom. More recently, we've been pushing the agenda with Sylvia Jones. Other ways of raising awareness and funds for scleroderma have been, I've led a bike ride every year for a few years to we've raised over $20,000. And those of you who've raised any money know how difficult that is. But it's all through collaboration and teamwork, like we've been discussing. So with this wonderful team that one year, comprising of research coordinators, family members, students, patients, we have raised that much. And on a much more humble level, this year I cycled 380 kilometers in the Outer Hebrides in Scotland. Those of you who would even contemplate that, let me know and I'll give you the itinerary. It's amazing. But what was most amazing, number one, are these absolutely pristine white sandy beaches, which you expect to see in the Caribbean, not in northern Scotland. And I was very lucky because you can see something else in these photographs, and it's called blue sky. And that doesn't happen so often in Scotland, but it did happen for us, and we had a wonderful time. But anyway, we raised $2,000 or just over $2,000 there. I mentioned earlier, I was in the right place at the right time when I was invited to apply for the directorship of the Canadian Scleroderma Research Group. and this door definitely opened for me. This is a nationwide and international collaboration amongst interested rheumatologists and others across the country. And our premise, like many premises of big cohort studies, is that research changes how we treat our patients. We have a clinical problem, we think about the clinical, translational and mechanistic research that allows us to try to answer the question, giving us a much better understanding of the problem. It involves a lot of collaboration and advocacy and education, and that's what the CSRG, or Canadian Scleroderma Research Group, is all about. This is the legacy that I inherited. What a wonderful legacy. 20 years of dedication from many clinicians across Canada, data from 1,600 patients that we have ready at our fingertips now, 15 sites across Canada. And think of this, in 20 years we've had over 100 publications. Again, those of you who publish papers from cohorts will understand that 100 publications in 20 years is really, really impressive. And that's the legacy that I've inherited. And the new executive are listed here. I won't dwell on this, although I'll just have to quickly go through the photos. What about my immunology collaborations, just the final part of my talk? Our immunology collaborations are really to follow your heart. And that's what I've really wanted to do. My PhD was in basic science immunology, and I've really wanted to do that. And the way I've made it work at McMaster is by collaborating with some wonderful basic science immunologists. For example, Dr. Dawn Bowdish, who is an immunologist here at Mac. And she and I actually simultaneously decided that we really need to help answer this question. And it's a question, yet again, from our patients. And our patients said to us, if I get COVID, if I have a COVID vaccine, am I going to mount a decent immunological response to this? i.e., will the vaccine work for me? And what we didn't know was the answer to that question. We know from other vaccines that sometimes they don't work so well in certain groups of patients on certain medications. So we wanted to answer this question. And at the same time that Dawn and I were chatting about this, we were given the opportunity to apply for this grant from the COVID Immunity Task Force, a Canadian task force. And at that time, there were 3 other centres across Canada who had put in a similar grant. And so we were asked to collaborate. And so McGill, Toronto, and McMaster all collaborated on this study, and ultimately it was expanded across the whole country. And we gathered 2,000 patients. We did a finger prick blood test on them. Some of our patients had also a proper blood test so that we could look at some cellular immunology. And we had patients with various inflammatory arthritis, with inflammatory bowel disease, and with psoriasis. And locally, I also gathered patients with systemic sclerosis. And this is just one of the studies we were looking at. We were looking at whether those patients, the question was, did they have a robust immune response to the vaccine? And these are our methods. I won't go through them in great detail, but we looked at the humoral and cellular immunity to the vaccine in patients with rheumatic diseases on immunomodulatory drugs. And these were our methods. We looked at the antibody to the receptor binding domain and to the spike protein. And we also looked at spike-specific memory cells as well by flow cytometry. I'm going to just show you some of the data on the antibody responses. And here you see the graph, both graphs are antibody responses. The first graph, panel A, is anti-RBD, receptor binding domain, and the second graph is anti-spike. It doesn't actually really matter. On the y-axis, you see the level of response, and the higher the response, the more immunogenic the vaccine has been, i.e. it's induced an appropriate response. And these are patients with rheumatoid arthritis in the bottom here, and across the x-axis is time. And patients with rheumatoid arthritis are here, and this first point is after dose 1 but before dose 2. So after dose 1, compared to healthy controls in the squares up here, you see that really they do not have an immune response. They're under the level of detection, whereas the healthy controls do have an immune response. But that immune response comes up after dose 2. So essentially, patients with rheumatological disease, or rheumatoid arthritis specifically, need that second dose to boost their immune response, which then wanes with time. And what we're looking at now is what happens after dose 3 and dose 4 and so on. So that was interesting. We found that interesting and really encouraging to our patients to say, you definitely need to have at least the second and probably third and more. And interestingly, I told you we were looking at systemic sclerosis in our cohort. This graph is set up slightly differently, and what you've got on the x-axis here are healthy controls versus systemic sclerosis at 2 to 4 weeks after dose 2, and then at 3 months after dose 2 in the next couple of columns. And you see the healthy controls soon after dose 2 have an antibody response, but half of the patients with systemic sclerosis did not have an antibody response. And that only developed, as you see, with time. With 3 months after the vaccine, many more of them developed a more robust immune response to the vaccine. We don't quite understand this, and that's work in progress, and that's one of the exciting things about basic science research. And I'd like to acknowledge Dr.to-be, PhD student Jenna Benoit, who produced these slides and produced this data. So the conclusion there, I won't read all of this, but essentially patients need at least one booster, and now we know more. Another part of immunology that's been really dear to my heart, mainly because of my wonderful husband, Dr. Mark Larché. Mark has been developing peptide immunotherapy for patients with allergic disease. And years ago, 20 years ago, I said to him, that's too easy. We have to look at autoimmunity. And of course, I'm a rheumatologist, so I was a little bit biased in that decision. But anyway, Mark bought into that suggestion. And we've been looking at rheumatoid arthritis, and I'm going to just show you a little bit of data in systemic sclerosis, where we've been just pushing that boundary. And I'd like to thank our colleagues, Dr. Ryan Quinn and Dr. Bagavi Devuri, who have been involved in this research. I won't go into massive detail on this, but suffice it to say, this is called a Manhattan plot because the higher the skyscraper, the more important the signal. And what you see here is this really big peak that I've outlined in red. The peak is black, but I've outlined it in red. And other peaks, as you see here and here and here, are important immunological markers. And they give us a clue that there's a link between immunology and genetics. We know that already, but this is in systemic sclerosis patients. And so what we decided to do was look at the different types of systemic sclerosis. And we have a diffuse subtype and a limited subtype. And as you see in this depiction here, we have different molecules that seem to play a more important role in diffuse, anti-RNA polymerase 3, for example, and anti-SCL70, and a more prominent role in limited, anti-centromere here. And when we look at the genetic predisposition to those proteins that have antibodies formed against, we see that there are actual genetic subtypes that may trigger that. So we're getting a clue about how a blood test, these antibodies that you can measure in a blood test, how the genetic profile of that patient may drive the phenotype of the disease of that patient. And so what we did was we used Mark's premise in allergy, and we took those proteins and we chopped them up into little pieces. And those little pieces of protein are called peptides. And peptides sit very nicely into the gene, or it's called the HLA groove. And Mark uses the lovely analogy of a hot dog bun. A hot dog bun has to be the correct shape to fit the hot dog. And if it's not the correct shape, it doesn't fit nicely, and you can't get your ketchup in there and whatever else you put in. And so the peptide has to fit beautifully into that groove. And so we chopped up these peptides to try and fit them in the groove, and if they fitted nicely, they generate an immune response. If the hot dog fits nicely in the bun, it generates pleasure when you bite into one, if you like hot dogs. So that's the analogy that I find really useful. So this is some of the data. I've blanked out the actual sequences because they're not prime time viewing yet. But essentially what we showed was that some of those peptides generated an immune response in our blood from patients with the correct HLA typing. And now we want to use those peptides to harness that immune response to try to prevent the disease from progressing. We're a long way off, but it's super exciting, and I'm really hopeful that we can get somewhere. And thanks to Mark and the rest of the team and the Scleroderma Society of Ontario and the Hamilton Scleroderma Group for helping with funding for this study. So really that's my journey through research, from the same as Peter, from cells to genetics, environment, a little bit of cohort studies, looking at clinical phenotypes, epidemiological studies, all to try to get clinical solutions to improve patient care. So Peter has really been integral to that. I'd love to just finish with this. Peter's shining light shines on all of us, and it still does today. He's touching all of us still now. I promised myself I wouldn't cry, and I'll really try not to, but he was so instrumental in my career, both professionally and also personally. I want to express my immense gratitude to him and for encouraging all of us in that spirit of collaboration. So thank you, Dr. Peter Dent. Thank you, Diane, Jennifer, Ashley, and Rebecca, for being part of this and for really pushing for this Dr. Peter Dent Memorial Lecture Series. And Peter, you shine your light on all of us, and it propagates and multiplies. Thank you very much.